Good morning and welcome to here live from New York at the Mount Sinai Fuster Heart Hospital. We are very honored to have you join us once again today for our holiday special. We've I think we've always towards the end of the year we always kind of think about all the cases we've done so far and all the educational topics we've been able to discuss, and I just want to thank all of our partners, everybody who's been kind enough to join us as guest moderators, both live and via Zoom. And it really has been a great year so far. You've had an excellent NYEBS earlier this fall, and we look forward to closing out the year with a bang, as we always try to. That being said, we have a lovely, quite challenging multi-level CTO case live for you here today. And I think since it's going to take a long time, let's jump right to it. And PK, why don't you tell us about what's going on?
Well, thanks, Raman, and thanks for the nice intro, and welcome everyone. And as Dr. Sharma said, we're really grateful to all of you for tuning in. I think we had, I'm going to get the numbers soon, but the largest viewership audience in our history of peripheral live cases on CCC, the peripheral side. So appreciate that and appreciate everybody who helped us. But again, I'd love to welcome Dr. Vishal Kapoor, our director of Mount Sinai Morningside, Shalini Mani, our endovascular fellow, Ray Lascano behind us, and our wonderful nursing team with Alina and Denisa. We've got Peter as well as Damien here. So we've got a fantastic crew, and I really appreciate them. But we got a really tough case, Raman, and that's why we got started early. So let me tell you, and Denisa and Alina can vouch, we got access at 7:20 to get started because we knew this was going to be a little rough. So without further ado, I'm going to have her presented, and we'll discuss the angiogram. Go ahead, Shalini.
Good morning, everyone.
Louder, please.
Next slide.
Big green one, yeah.
It's not moving.
Okay, it's not working.
Next slide, please.
Go to the next slide.
Next slide, please. Good morning, everyone. Our patient today is an 85 years old female who presented with severe lifestyle limiting claudication progressing to ischemic respine, Rutherford Grade II Category 4. And the past medical history is notable for diabetes, hypertension, and dyslipidemia. She has polyvascular disease with previous multiple peripheral interventions, the last one being left SFA POP intervention. She also had CAD and multiple PCIs to LAD and circumflex. She also has hepatitis C. She's not a smoker, and in terms of medication, she's on antiplatelets, statins, AC inhibitors, and good anti-diabetic medications. Next slide, please. The diagnostic peripheral angiogram here shows doesn't show any significant inflow of disease, and the right pictures are the SFA POP pictures post-intervention. Next slide, please. The diagnostic runoff of right lower extremity here showing diffusely calcified multi-segment disease of SFA. This is severe disease in the POP segment with a single vessel inflow, probably a collateral inflow to the food with another CTO at the proximal AT.
So Raman, as you can see, this is a lady, I mean, she's been with me since 2004 or 5. And maybe go to the main angiogram, guys, and Dr. Kapoor will describe it.
Yeah, can we see the screen? All right, good. So like Shalini talked about and like PK and Raman talked about, it is the multi-level case right there. So you can see the right side as shown in the PowerPoint presentation, but more clearly here, it's multi-segmental, diffuse, calcified lesions in the proximate and also extending into the distal SFA. You can see the calcification. And the real crux of the story comes below the knee, where you can see there's a one vessel perineal runoff, which also just phases out.
Well, it's really just a collateral.
Correct, exactly. And it's pretty much all three vessels are occluded proximally. stump occlusion of the TP trunk and the peroneal PT. AT, there is some proximal flow, but distally, it technically reconstitutes via all the collaterals. You can't see anything else, but really a distal DP in the mid 1/3 of the foot. So here you can't even see it's rising up. We'll take a more magged up shot right there, and then you can ascertain. So this is the proximal segment that they're talking about where the lesion is.
In the popliteal.
In the popliteal. Tight calcified lesions, they had to cross through a support catheter, and then eventually this is the below the knee shot. So you can see it's stump occluded of the TP trunk, the peroneal. You can see a small stump coming in the mid segment, but the AT is occluded proximally, and so is the PT. And the foot shot right there, you can see the DP reconstitutes right at the ankle level. So essentially there is nothing before this, you could say. Right. So that's where we stand right now.
So Raman, I mean, this is a lady. She's quite active. I mean, she's quite active. I know the family, like I said, for many years. And so we initially did a revascularization of the inflow, which we've done multiple times to help these collateralization, but she never really improved. And then that restenosed, and so therefore, what we felt was this time. We sent her to our colleagues for questionable, distal bypass. So our colleagues in vascular felt that, 85 and rest pain, but it's a very, very small target with multiple comorbidities, no vein, not really a good target to go down to the foot. So what we felt was we can get her out of rest pain by opening this, and so what we decided to do was we decided to plan for a multiple approach. So you could see here, it's very important. Couple of things that just to talk about that you, me, and Vishal do all the time is to get the catheter down. For those watching at home, you want to go to the level of the popliteal and take really selective pictures because you're always going to have underfilling when you shoot from above. So you can see here in this picture right here, you can see that you have the lateral large branch is a collateral. Correct. It's obvious that it's a genicular collateral giving rise to it. But the AT stump is kind of there. You think it is, so you might have to probe that with a wire. And then down below, you could see here with a good injection, you could actually see a pretty robust DP, although diseased. So Dr. Kapoor went ahead and got ultrasound guided access here. So we got ultrasound guided access, and again, our technique is always, hockey stick probe and then ultrasound guided access. And in this, we just put a microdilator in. Once we put a microdilator in, we went ahead and switched that out to, again, for the sake, you can see how calcified it is. We switched that out to we give our cocktail, and then we switched that out to a Gladius 018 wire, through which we went ahead and advanced a microcatheter again, and this time we switched out to a what is it called, a 018 Trailblazer. Correct. So then what we did was we came from above, Raman, and we probed the cap with a what was that, Ray? No, it was also Gladius. Yeah. So we probed the thing with the Gladius, and you could see the Gladius was able to penetrate the cap from above and below. So then we decided to do dissection reentry because and Dr. Kapoor, maybe you could show up the ultrasound. They can't see, right? Yeah. So we did an ultrasound to show that we were within the lumen below, and then we started to do just basically dissection reentry because we felt that you can see. And again, the technique is really kind of probing, allowing the wire to prolapse. And you can see here, once it prolapsed, we took the prolapse, kept the loop small, and then started to push it up very, very slowly. And you could see it started to go a little bit off, so I was a little concerned. Right. But we're like, let's go with it. And then we checked with the ultrasound to show that we were within the lumen. And then here, Dr. Kapoor, again, very, very gently pushing the wire, pushing the catheter as I advanced the wire. And that's an aggressive loop, but I felt like, okay, well, it's going pretty smooth. Let's just go ahead and do that. Then at that same time, we came from above, and then you can see from above, maybe Vishal can play this one. There you go. So you can see, so we gave with an 018 Trailblazer from above, and again an 018 Gladius, and this time Ray and I were advancing it slowly. You can see here that slowly with sort of the push-pull technique, we were able to push the wire, pull the wire, and then advance the catheter through the calcified plane, and then slowly start to advance. And here the loop is much more favorable as we're coming down. So at this stage, Raman, we decided to stop because, again, we didn't want to, kind of do the whole thing offline. And this is what I mean by allowing the wire to advance. Here, Dr. Kapoor is pushing the wire as I'm just letting the wire go, and the wire is finding the plane as it goes up. So now at this stage, this is where we're at. So anticoagulation-wise, Raman, as you know, we're in. We have a bivalve Rudin. Our ACT, Denisa, is
more than
370, and which is fine. We've got her fully sedated. She's in no pain. 7 French sheath up and over. And I think looking at these 2 loops, I mean, I have my thoughts on where what I want to come down from. The bottom loop is a little bit too large, in my opinion.
Yeah.
Top loop is a little more reasonable. So Ray and I might try to come from above and see where it goes. So while we start working, you and Vishal discuss any other things that you could have done, any other differences.
Yeah. So I think just to bring out a point, Raman, just to cut you off. So the real thing about just talking about the access, I think, which is important, is where Peak and me talked about is when we have such distal DP reconstitution, we try to do a more distal DP access under the hockey stick, so you have a little bit of running length room, and we can advance any of your micro catheters. And as you can see, and Raman and me both do it the same way, is having a sheethless approach from below, using your support catheters as your technical sheet, so to say. So that's where we had to get. Normally we would not go that distal on the DP, but in this case, because of the lesion, we had to go distal down, and that was the only thing I wanted to bring it up. Sorry, Raman, keep me quiet.
Yeah, no. So guys, this is you have a lot on your plate right now. Luckily, you guys are going to be kind of, for the audience, we may be watching paint dry for a little while, but I think there's a lot of things to discuss. And I think I want to begin at the very beginning of this entire conversation.
Nice.
One of the first things, PK, that you had said was conversations that were had with the vascular surgery. And I think that's a very important concept.
Okay, stop there.
This is a patient who's had multiple revascularizations and has proven multiple failures as well. So the idea to even begin the discussion with vascular surgery to at least consider what would essentially just be a pop distal tibial bypass, everything more proximal can be taken care of endovascularly. I think that's a very important conversation to really have. Even if they do end up saying no, I think it's an important concept to keep in the back of your mind that at the end of the day, patients who have multiple failures, bypass should always be one of the conversations that are always had. Now, being 85 years old is not always a guaranteed contraindication, but I think another couple of caveats to keep in mind is the lack of a venous conduit in this particular age group. I think may not warrant itself to be as important of an issue, just considering the overall age. So that's one concept. The second thing is, the gladius wire. I think that's actually before we get to that, the distal DP axis. This is a very challenging axis to get, especially this far down. One of the main problems that you'll see is that when we get the DP axis, and as a wire, the initial Australian wire, or whatever axis wire you have, usually that wire will find some little tiny channel, and it will help kind of guide you in some good direction as far as which way to go.
Pull back the catheter above.
But in this case, that proximal nub was really just a giant rock. And we saw that even with the Australian wire, there was really nothing to really go to.
Hold on. Catheter back.
I do want to ask, as we progressed, as we move forward,
you see it's going this way.
Wire
choice. Weird. Yeah. This should go.
The wire choice of the gladius wire. Now, as mentioned a number of times, she has densely calcified disease, but the wire choice was the gladius wire more to do a dissection re-entry, as opposed to just a more traditional approach to CTO interventions with a higher gram tip load wire like a Confianza Pro or 12. PK, maybe you can talk a little bit more as far as why in this particular case the decision was to go with a gladius, if I'm correct, a 3 gram tip load wire and the dissection re-entry, as opposed to more traditional CTO wire like a Confianza or a Stato.
Well, I think it's just too long a segment to try to stay within the lumen. I think that dissection reentry is probably the right tool here to do, and you can see here that's kind of a pop that you felt there. Take it up, Vishal. Ray, pull out your wire now. Yeah, pull out the wire, leave the catheter, take it up further, Vishal. So we're going to try to get really close here. Okay, stop there, Vishal, for a second.
I'm going to fluoresce that 1 second.
And so I think we know that we're going to have to balloon angioplasty this. We have to IVUS this, probably scaffold part of it. you know, and the idea here is this is where we're going to come from above and below. So I'm going to kind of lose my wire here. Kind of afraid to lose my wire. See, it's kind of going to the side there. So that's the worry right there, that I don't think I'm quite in the right plane. You could see there. Now maybe I'm closer. Go forward, Michelle.
I don't like
that.
You change the angulation to see.
No, yep. Pull back your catheter a little bit, Ray.
How close you guys are.
Well, yeah, just, yep.
We're going to give you a little bit different view.
I'm going to give you a little different view. Go up a little higher, Michelle.
Yeah.
Because I know this wire is in a good position. It's just the above, I'm not sure. So I don't want to lose my loop yet till we go to a different view. Go to a different view here.
Let me go.
That looks good. Okay.
I'm going to go extreme RU, and then I'm going to switch to it.
Okay, now the other view. Okay, that's good. Okay, we're a little off, but that's okay. I think we're reasonable. Ray, come from above and try to tickle my wire.
I think it's now we're LAO.
Come from above with something and try to tickle my wire a little bit.
I think we're good on that. If you look at the LAO. Pretty good.
So so that was my logic, Raman. I think if we sat here with a regular wire, we would have been sitting and just kind of working this for a long time without, keep going up. Without really, that's going to stop there for now.
Maybe using a starter, like a re-entry, like a configure or a starter.
Try to
switch to a stiffer,
Okay.
We could probably enter.
Let's see. Pull back your catheter now. This is where we got to think about reverse card. Pull back your catheter, Michelle. Yeah, let's come down a little bit now. Let's try to play. Give me an Astado.
Give me an Astado, please.
Pull back more. Come, Ray.
No, take a wire, PK.
Come, Ray.
Oh, no.
What happened?
You should have taken a wire.
Ray, I think, is going to cross here. Oh, almost. Nope, almost. Okay.
Yeah.
Huh? 014, 018?
014 is that.
014.
014.
Pull your wire back a little. Okay, let me try the 014 now. Here. So Raman, I mean, how much do you try? When do you start going to a card or a reverse card or something? I mean, it's obviously in this case it's going to be a reverse card. Wire introducer, guys?
Yeah, I mean, so I started to do a pretty systematic approach now. You know, in certain cases where I feel as if there is an option, an opportunity for antegrade success.
I think you crossed. No, I thought I got. Oh yeah, you crossed. Crossed. Beautiful. That's it.
Excellent.
Come. Keep coming.
Good.
Nice. That's what we want to see. Beautiful. Let's externalize this now.
Yeah,
so
usually
Go ahead. Go tell us.
No, I mean just as far as like the approach. Usually I'll give myself about a 30-minute antegrade timer to cross if I think that there is an option. If there's not, then up front I usually give myself, if I get bilateral, both tibial and
No, you just pull that out now.
No, wait, let it. You see the wire in the catheter?
It'll come. This is Flora, guys. Flora, and you'll see.
Yeah, no, just want to make sure.
So Raman, I think that what people at home have to understand is what we were doing here is a dissection re-entry.
Yeah.
Okay. So what happens is you create multiple planes up top. When you create multiple planes up top, that's why all of us were talking about confianza versus this versus that, right? Because the idea here is you've already used the hydrophilic wire to create the plane, right? Now you can pull that out. Okay, now get us an IVUS, guys. So once you've created the plane with the confianza, with the hydrophilic wire, the idea is not to make the plane too large. When you don't make the plane too large, that allows you to be able to go with a sharper tip wire to perforate the septum between the dissection plane and the true lumen, because you have a wire from above, which is in one lumen, and a wire from below, which is in the other lumen. So if the wire from below the lumen is large because of your what is it called, your loop, then what happens is the wire from above has a very tough time finding the true plane to get into your catheter. So even though in the bottom our loop was large, when we started getting up top, we were very, very particular about keeping the loop as small as possible. So you notice that I extended the plane above by pushing from below, but the loop was small, almost to the curve of the AT. So at that stage, when I pulled back, Vishal was able to go from above with the Astado or Confianza or whatever he decided to go with, and was able to perforate the septum and then drop right into the 018 Trailblazer. So now we're in true lumen above and true lumen below. Now, what's in the middle? We'll find out.
Yeah.
So what we're going to do now is we're going to IVUS, and then let's talk about therapy, and then of course the SFAs. We can just mention what we're going to do. So we're going with an 018 IVUS. Our IVUS team is here,
mag out
and so he'll let us know how good or bad our cross was in a second. So you can see here Vishal's coming with the IVUS. And I think it's important to establish outflow. Part of the reason she failed was outflow, and I'm curious to see what happened to her sheath above too, Ray.
It's okay. The sheath is good.
Is it going to go? There it goes. Oh boy, this IVUS is tough.
It's a rapid.
Yeah, here it goes. There it goes. Come on.
I'm not a big fan. No, it's my sheath is
not going to go. So we're going to have to kind of balloon this here, Roman. I hate to do this. Give us a 2.5 long balloon, guys. There's a 2.5 300 balloon, the BD balloon on the expiry date shelf.
Yeah, make sure we use that quickly.
Yeah, exactly. Exactly.
We have another hour left before it expires.
So the plan here, Raman, is let's talk a little bit. So let's create some scenarios. Yeah. You're intraluminal, but you have some subintimal planes. I mean, what is your therapy? You're totally intraluminal with fibrocalcific lesion. What's your therapy? It's not heavily calcified. We don't see angiographic calcium. So what would your thoughts be, Vishal and then Raman?
Well, I mean, my goal in this case, like I said, is we have a proximal and a distal cap. I'm sure once we do the IVUS, we will know that we probably were the subintimal as well. That's definite for sure. So in this case, I would probably just do a balloon angioplasty right now and maybe just use a cutting balloon to give me a little bit more luminal gain, like a serenator balloon, which I'm a fan of, and then do that. And then depending on if there's a recoil or a significant dissection, nowadays we have the liberty of using our drug-eluting scaffold below the knee, right? Which is the Aspirin Abbott, except for the last 10 centimeters.
Wire up top?
Yes.
Okay.
So that would be my strategy, is just cutting balloon and stent, the scaffold wherever possible, except for the last 10 centimeters as indicated in the use of the drug-eluting scaffold. Raman, how about you?
Yeah,
Would you be an atherectomy guy?
That kind of depends, because like where that IVUS started, where it got stuck, you look pretty far outside. So I guess we'll see what the rest of the vessel looks like.
Right.
I think the most important thing is kind of how you ended, was about the idea for a scaffold, considering how many times she has failed. This would be a patient who I would void the scenario in which we have 0 scaffolds available to us. She would get off the table with at least 1 scaffold.
Right.
I mean, and I don't foresee that ever really being much of an issue. I mean, I think she most certainly requires outflow, and I think if outflow was a question to begin with, when the previous SFA and were done, then perhaps perhaps this is going to be what's going to allow this to be perhaps her final intervention of the right lower extremity.
No question. And Raman, you made a good point, because it's a question of now we have actually an FDA-approved scaffold for the below knee. It's randomized against balloon. Obviously, this lesion wasn't randomized, as we all know. We all were participating in the trial. But the idea here is that you definitely want to be able to at least scaffold multiple scaffolds here, possibly, and then decide. I do agree the IVUS looked a little weird on the outside there, but again, this is one of those lesions. 6 guys. So this is a 2.5 balloon, Raman. We're being a little conservative, going with a 2.5, so we can run the IVUS through. Down, guys, and walk it back. And remember, we still have that pop inflow lesion as well. Yeah. So.
Yeah, you have a couple more lesions to go, but I think this is. I think the durability, the long-term durability of this case will be determined solely by the AT revascularization and the final angiogram of this tibial vessel. Now I have another question. Now let's say that you do this and you get your beautiful pictures of your AT all the way to that proximal DP, knowing that there's no other tibial vessel going down to the foot, essentially, besides genicular collaterals and all these other short bridging collaterals.
Right.
Let's say that the mid and forefoot doesn't have any good pedal arch.
Yeah.
Would you then go even a little bit further, try to fix a pedal arch?
Probably not, because she's rest pain and not an ulcer. So at this stage, I think if we open this, she's truly claudicating at 25 feet. I mean, she really is not doing well. Walk it back, guys. We'll do a DSA.
Yeah.
So I think what we'll try to do is we're going to keep that. And another trick for everybody is when you walk it back, don't detach the balloon, right? Are you out, Michelle?
I did.
Yep. And so don't detach the balloon. And then in case you have a perforation, you can go right in and you can see what it is. So we did not, hopefully Vishal did not detach the balloon, but that's something that Ray and I do often where we don't, it's all saline?
Yeah, give me 1 second. Let me walk it out as well. I haven't walked it out.
It's still in the vessel?
Yeah, I was just getting out. That's how I was.
Okay, there you go.
I just want to make sure I don't kink my wire. I'm very.
No problem. You're good. So here's
just to be clear that, dude, we are, for everyone watching, the wire right now is going in from the left femoral sheath and is clamped outside of the right DP.
Yes.
So,
and I think we
essentially have an infinite amount of pushability right now. Avoid the crazy stuff that can create a lot of problems. So
you're right.
Know that you have comfort in the amount of pushability that you have, but that doesn't look good.
A little bit of AV fistula maybe. I don't think it's a perf.
Very proximal. I think it's a change the plane big time in a single segment. That part 100% must be scaffolded, I think.
Yeah.
So in this case, like Raman talked about, having the wire outside gives us all the pushability in the world, and we in this case we'll keep it out or we'll keep it externalized till the time we pretty much have our definitive therapy down there, and then we can rewire to see.
All right, so that's beautiful. All right, let's go with an IVUS now. So we're gonna do the IVUS now, and then we'll decide. I have a good feeling here that I think we're definitely going to scaffold. So
I have blood coming from the side, which is great.
Let's go ahead and get some, what is it called, scaffolds. I would say 3.0, 3.5, and 3.75 scaffolds.
No, I would prefer that we prep the lesion because we used the 2.5.
I'm just having it ready because it's going to take some time. And then we're going to do the IVUS, and then we're going to decide how to prep. So we're just going to do an IVUS here, Raman, and we're going in. As you can see, obviously we're going to have to do multiple levels. We'll do that offline. I think it's really more important to do the tibial here. So to show everybody, we do have plenty of time though. So IVUS is now flying, of course.
Damien, a little bit of slack.
Yeah, we have 34 minutes left. I mean, I think this entire case is going to be done. Yes, look at that.
That would be nice. So here we're going down with the IVUS, and okay, now he's going to go all the way distal, and that's okay. A little bit of action going on. Okay, can you put the IVUS up for Dr. Sharma, please?
Yep, it's up.
Okay, we'll go a little further, Vishal.
That's it, I'm hubbed.
All right, you're hubbed. Okay, we're going to start from here, Raman. So record, please. Pulling back.
Yeah.
So again.
It looks in the vessel there. That looks okay. This part, at this segment, the loops seem pretty small, so everything seems consistent.
Yeah.
And right there, it seems like we've jumped
maybe a little bit of subintimal, right? Exactly.
Right here, we see the intima going around. So that's okay. But this is an expected portion. I think we would even expect to see versions of this, even if we were to be using a higher tip load wire like Confianza.
Back in the lumen.
No, I think you're still outside.
Still subintimal,
yeah. Now we're subintimal.
Now we're back subintimal.
So there's a good portion. So right there where you just passed, very much subintimal, almost adventitial. You can actually see the intima and the media very, very well here.
But here we're within the lumen here.
I think
no, not yet.
You can see it at 7 to 9.
Yeah. Now we're not.
So there's.
That's the mid portion where it looked big. Yeah.
Yeah. So now, that even right there was another big segment. Okay. So a good portion of this. Wow. Yeah. So over there, really far out.
All right, so what do you guys want to do now?
So I think atherectomy for me is 100% off of the table.
Wow.
I think the next thing would be to then talk about what would be the rest of the lesion prep. I think PTA would be okay, but I think considering how far we are, I would kind of prefer to do some form of atherectomy with a serenator or something, just to really try to do what we can to give full luminal expansion, considering how much of this vessel we're actually sitting outside of the intima.
So that's fine. I personally, I don't think it's atherectomy is off the table. I would do directional, but I agree with you in this case. But since we're going to scaffold, let's go ahead and do an atherectomy. I think that distal area needs to be debulked. You'll probably have a better outcome with an EXL and followed by a serenator. But then we've got the SFA, and I want to talk a little bit about economics as well.
If we've got the SFA. Because I think there's the mid to proximal portion. That's where there is a lot more
Exactly.
What's the size? Size of the vessel?
If the atherectomy is more related just for the distal and mid portion, I think that's reasonable, because the much larger
Serenade long.
Yeah, the much larger subintimal space was seen. And again, all of this corresponds to what we saw in the angiogram during the actual cross.
And also, it's funny because we predicted it while we were crossing.
Yeah.
Serenade long.
So I think that's a beautiful point that Raman brought up, is like the loop angiographically was a real determinant.
Bring that up. I brought it up.
PK brought it up, which is supported by Raman and corroborated by Raman.
Oh my God.
Yeah, but angiographically, like I said, when we talk about, that's the reason we were very conservative about the loop. You know how people say big loops.
What happened to my screen?
So I think that's what happens when you get big loops, is where you go subintimal. And we actually showed in the IVUS that really the tendency of going subintimal and way deep in, like Raman was talking about, almost approaching or touching the adventitial portion is important. That's why we want to keep the loop smaller in size, in length, so that way we try to stay as much close to the lumen as much as possible. Now, I mean, talking about data and now the scaffold, would you say, do I really care? Probably not. But sometimes when in the no scaffold sections, you still want to maintain the integrity of the vessel and the outflow. And especially in this patient who's had repetitive interventions, I think you want a good outcome, even though, thank God, no ulcer at this time. But giving her the full benefit, I think, is where it's important. And Raman's point of being subintimal and IVUS is actually very important in this case. You have the wire?
I think I think the most important thing to take away now is that what can be done. We're hounding this topic over and over again, but what can we do to ensure that this tibial outflow stays open? And I want to bring the conversation again to the pedal revascularization, because I think that's an important conversation. We don't really have it enough. Vijay, why don't you talk a little bit more about, in your experience, when would you choose to be more aggressive with your pedal arch revascularization, and what exactly would be driving you? Would it be multi-level disease, only ulcers, ischemic rest pain, multiple failed interventions that you believe is just because of pedals? What's your way to approach these?
So I think, in this case specifically, I mean, it's all about a lot of clinical presentation. In this case, like we talked about, it's grade 2, category 4, Rutherford rest pain, but no real ulcer. So in these cases, we're getting the inflow in, which PK has already tried before, and with a good tibial outflow would be my primary goal or aim or definitive therapy. Patients who are coming in with ulcers, non-healing wounds, and like you talked about, if they have an incomplete arch or disease distally into the digital vessels, in those cases, we definitely want to be more aggressive and bring them back and try to do whatever needs to be done by either completing the loop, retrograde access, or even antegrade access into the AT, into the DP, and trying to complete the loop. So it's depending on the presentation, I guess, is the most important driver for me in these cases. Of course, there are some objective evaluations, pedal acceleration time, and all those things, which are more important when you have ulcers. And I think in her case, especially based on the data from Aspirin of below the knee intervention, giving her that opportunity should hopefully also increase her chances of keeping the vessel patent longer enough for her to have a good outflow. So the goal in this case is like essentially making her rest pain go away. So I think in this case, intervening on the AT primarily with now additional therapies, I think should suffice. And we can, of course, clinically follow her and see that she doesn't end up back into rest pain or even in ulcer. In those cases, of course, we go more aggressive on the pedal arch revascularization as one of the strategies.
But I think the issue here is that I know I missed a lot of the conversation. I don't want to repeat myself, but we did talk a little bit about scaffolding. So
before we get to that, I think since we're kind of just waiting for all this stuff to kind of reboot, let's talk more about this. I asked Vishal about kind of what would his strategy be, because I wanted to talk about this whole pedal arch revascularization, just because I think it's an important conversation to have, especially as the slowing gaining more and more traction. In your experience, what are the drivers is that would kind of push you to be more aggressive with your pedal arch revascularization?
I think honestly, it would be the clinical scenario first of all. I think pedal arch revascularization is very, very dangerous. As you know, we don't do a lot of it here. We've done it in the past, and the reason is if you have any sort of dissection of the digital vessels, you basically end up with a forefoot amputation. So you kind of have to be at that scenario where you've ruled out all different types of therapy in order to help the patient. Surgical bypass, adequate debris wound, inflow, adequate, tibial vessels coming to the foot, and then saying, okay, wow, even now the outflow is not enough. The idea is also what are your goals of therapy? Your goals of therapy are always going to be leaving the patient with a functional foot. So if you're going to lose the digits, that's fine. If you can leave them with a forefoot and then allow adequate heel, then I think you're going to be able to allow the patient to walk. So to me, pedal arch revascularization indications are very, very small, especially now with DVA that's available as well. Usually we will attempt pedal arch before we do DVA, but at the same time, it's few and far between, Roman. I believe that in a patient like this, you should not do it. We've got great flow into the foot, so therefore, I think her rest pain will 100% go away, and it's just a question of getting a durable result. And I think the durability of the result is what you guys were kind of talking about vessel prep and things like that. And for me, this is a patient, that 170 millimeter lesion has been studied with the Life BTK study. However, this balloon alone was 220, and we ballooned it twice, so it was almost 350 to 400 millimeters. So the idea here is we're really in territory that we don't know. There's two factors that I think that I always consider is what is the cost. So now I think what the template is going to end up being for all of us is that we're going to use scaffolding in the proximal. We're probably going to use limus coated balloons in the distal, as both of you know. We're part of the Magic Touch. Trial, which is starting for the below the knee. So in the future, we may vessel prep with a serenator or atherectomy or whatever we decide to do, and then go ahead and do a sirolimus coated balloon distally, and maybe a couple of scaffolds up top just to tack up the dissections and be done. But this is a very, very challenging lesion subset, and I think that's going to be the major issue for us. So let me see. So as you know, the sirolimus coated study was presented in TCT. So obviously in Germany they did I guess single center. It was a randomized control study, but it was not a multi-center and it wasn't a large study. But however, they did find I believe it's called the Sirona study. They did find that you have a non-inferiority to paclitaxel coated devices, so therefore it is a non-inferior study, but however it's very exciting because now who knows what's going to happen below the knee. So that's going to be very, very interesting for us because that was an above the knee study. So let's see what's going on with the thing.
We're still working on the...
Okay, we're still working. So obviously we're blind here. So we're just going to occupy the time.
What else can we talk about? Let's talk about limus now.
Let's talk about limus.
As you made the segue.
Yeah.
I think that's an important concept, about what are the current studies that are being done. And from my knowledge, all of them as of right now are structured as non-inferiority studies. And I think I'm left kind of hanging a little bit because I kind of would really like to see just a study that's powered to demonstrate superiority. I think we're in a tough position because right now our 1 to 2 year outcomes with paclitaxel coated devices is actually still pretty good. So I think to power a study enough to demonstrate superiority may be challenging, but I think at the end of the day, that's a question that really has to be answered. Do we have a technology that's not non-inferior, but superior?
Device? The Sirona was against all paclitaxel coated devices in the SFA, I believe. You can look that up, Roman. I'm just talking off the top of my head. I'm not 100% sure what the name of the study was, but it was against all paclitaxel coated devices, and it was non-inferior. I know that BD is working on a project that may compare the two. Solution, I believe, is also in the SFAs against paclitaxel. The problem below the knee is the standard of care right now is still balloon angioplasty, and likely maybe Life BTK, which is a scaffold, or Aspirin BTK, which is a scaffold. So below the knee, we're still going to be up against what is it called, the PTA as the standard of care. However, at this stage, what else are we going to do? I mean, we have PTA as the standard of care, and we're just basically, comparing everything to PTA. So that's why, the endpoints are also tough below the knee. I think the endpoints in the past in the below knee trials were all flow and no flow. Now, with the Aspirin BTK study, we looked at binary restenosis, and it turned out to be a very important endpoint. So I think that our evolution of below knee studies and how we track our endpoints is also going to be important. I think wound healing as a primary endpoint is almost impossible. I think all of us would agree, because you need nutrition, you need offloading, you need wound care, so on and so forth, so many multiple different things to infection control to be able to ensure wound healing. So therefore, that's going to be another difficult endpoint. So I think we're going to end up with binary restenosis as the endpoint, and obviously patency as well. So this is going to be a very important trial. This magical BTK, as well as the solution study, are all going to be adding to that. So it's going to be very interesting.
Another issue is talking about what our definitions of our outcomes are. Is it's actually a real problem if you really consider it. The surgeons, the interventional radiologists, the interventional cardiologists, all of our different societies, all of them have different definitions for failure and patency. So correct. I think as we move across and we cross this plane towards everybody agreeing that there is now a more durable option, there has to be some unity in terms of how we are going to be defining it. And I think Esprit's binary restenosis was probably the most important objective out of all of them. Now, that being said, the previous trials with the coronary stents were also looking at binary restenosis, and I think part of the reasons why we don't see the same objective outcome. And I'm just saying this, don't want to be under fire here, but it's very common that a PTA or even an atherectomy over time, if you were to do a duplex, is going to show some binary restenosis. So all these trials are now going to demonstrate some other weird new finding, like clinically driven revascularization, wound healing, this and that, reversal. Like all this is like this silly stuff. Now, that's not to say that it is not impactful, but is there an objective, indisputable difference in outcomes based off an objective post-procedural measurable outcome? And I think if a transition is made to a unified
stop bleeding
decision,
it just stop bleeding,
of a binary restenosis, I think that would be that would be a very simple way to move all the different societies together to help collaborate and make a unified decision as far as what's actually the beneficial tibial interventions.
I think I agree with you, Raman. I mean, it's like we have to streamline ourselves. Being an interventionalist, we always compare it to the coronary field. So we technically need to streamline our trials and our vision and the endpoints to see how everything that we do has an objective evaluation side. Like we have a MACE in our coronary world, we technically have a male endpoints with major adverse limb events. But you're right, all the trials, because it's like a wild, or it has been like a wild west. Hopefully, it's structuring and aligning itself to one thought process. We've had multiple endpoints. One is by ultrasound. How is the ultrasound doing at 1 month, 6 months, 12 months as an outcome? Sometimes it's just your limb salvage outcome. Sometimes it's your amputation purely, which again, like PK and you talked about, is multifactorial. It's not like I revascularize and I decrease my amputation. There's a lot of other services that are involved in the care which could possibly impact. And then, of course, the randomized trials do take care of those idiosyncrasies as well. But at the end of the day, you're right. Having some objective evaluation, binary restenosis, maybe ultrasound findings, findings of restenotic PSVR velocities at 1, 6, 12 months are a little bit more objective evaluation. I don't know if we'll do a repeat angiography like we used to do in our left main disease. We'll bring them back, do an angiography, and see if there's stenosis or not. I don't think we'll do that as a part of in these cases where what happens angiographically, but more from a clinical perspective. Yes, I think it's important to come to a consensus. So that way, then you can truly compare one therapy versus a standardized therapy, which in, right now in this case, like we said, is PTA. And we all know PTA patency rate is anywhere between 37, in real world, 33, 37%. If you start going into the trials, they actually show 1 year at 60%, 50%. So it's very variable, again, of how the trials are driven, but hopefully with I'm more excited about, like you talked about, the Magic Touch, which we are all a part of, about all the Lima study below the knee, which has been disappointing in the past, but hopefully now with the advent of technology, use more acceptability in the drug-eluting scaffold part. Hopefully the Limus part, which takes over the Taxol, would probably give us a little bit more better results and outcomes for these patients who were initially non-eligible for any form of definitive therapy except for maybe PTA. And then I guess once we cross this step, the next question I guess most of the vascular surgeons will ask is, what happens if we compare to surgery? So that will be, those are multiple questions. That's another argument saying, okay, what if I do a bypass? What happens with that? So I think we have to establish our endovascular therapy as a definitive therapy by these trials, hopefully give a positive outcomes, and then eventually try to compare them with other forms of more aggressive therapy, you can call it, or open surgical or alternative surgical endovascular therapies as a part. But you absolutely brought it up correctly to the point that now we're making a faster headway in this field, especially below the knee. And then hopefully we'll have some good results. So let's see what these trials come up with. But yeah, we're still waiting, unfortunately, for the power. I'm going to ask PK if we...
what exactly is going on? Like
it's
the
just...
entire,
yeah, it just shut down. Yeah, everything is off. And they don't... Yeah. All the screens are off.
The lights.
Besides the light. The Mac lab is completely off. And where it's hooked up, they're not getting power source. I don't know. So we still not, technically we haven't rebooted as well. So we might, if I confirm with PK, we might, record this, whatever is left over, once it rebacks again, so that we don't have to waste any more people's time. Around 34 minutes.
Plans? I don't know.
We're going to restart. I have a feeling at 31 minutes, the power is going to come up, and Robert is going to say 3 minutes, finish the case, get out.
Yeah, exactly. Yeah. So have all the devices ready to go.
Yes, we are all ready. We have some shockwave. But good thing is, like we talked about, we do have very good, actually, blood coming out from the axis side. So that's a good sign. And then, let me ask you this.
I'm just gonna make a little suggestion. I mean, your ultrasound machine is still working, right?
It is.
Yeah. Why don't you go with the Serenator and just go via ultrasound and just get?
Yeah, we could do that, but then angiographically, I just do a quick. My balloon is ready to go. It's pretty much in the sheet. The idea is, even if I do it, I'm not going to see what happens to it. But let me ask you this, Raman, regarding the atherectomy. Let's say people let's say they're outpatient, OBL, they don't have an IVUS, so don't want to use an IVUS for whatever XYZ reasons. I'm not commenting on that. In those cases, how aggressive you are, if it's purely angiographic based, the last angiography picture, I'm sorry, I can't show you again, but I'm sure people and you remember, based purely on angiographic presentation post PTA. When do you decide to do atherectomy, or you say, you know what, it's too dangerous? Non-IVUS finding is like when a decision is. Yeah. Or would you do segmental, say, okay, procs look bad, I'm just going to do mid, or is it all or none for you, or you divide them into angiographic segments and do one part or one not?
Yeah, I think if all you have is angiogram, I mean, it's obviously there's the financial component of this whole conversation, which we don't need to belabor. I think we all
clinical,
this idea, but I think if the question about what are the angiographic drivers to support or dissuade you from doing atherectomy, assuming that directional is the one that you're going to be going with, I don't see what other one you can really safely choose right now. I think orbital atherectomy is out of the question, considering the way how you had crossed.
Correct.
So essentially, any kind of dissected vessel orbital is off the table. Laser in this case, I think, is not completely unreasonable. I think I'll be very cautious to make sure that you're doing it with only saline, considering that there are good portions of it that you did have extraluminal and subintimal crossing. I think if directional is the one, I think there is a segmented approach that's probably going to be the most reasonable. That one segment where we saw angiographically, where it looked like there was a column of contrast and then it shifted and there was the rest of the contrast, I would stay very far away from over there. I think the distal segment where it just looked like, pretty just diffuse atherosclerotic plaque, I think you can get away with it. It looks like this patient may be a little bit tall. So I'm not sure whether your device would actually make it all the way there. But I would basically take it to its hub and do that distal mid and distal area if that was so inclined. But that proximal segment where that more risky area looked, I think would definitely be enough for me to say that that's not where I want to do any atherectomy.
Yeah. I think that's a good point. I mean, especially based on the calcification, like you talked about, if it's more fibrotic calcified rather than a pure calcified lesion. So doing atherectomy, like Raman talked about, just directional atherectomy is the best option in this case, where you have a little bit of control both on the side as well as how far and how deep do you want to go in. So that would probably give us a good outcome if you want a little bit of luminal gain. I don't think, and probably Raman would also agree, shockwave here in this case probably doesn't have much role because we didn't see significant tram track calcification as we would expect in this case. And now we have an IVUS finding to corroborate that probably it's not really needed in those cases. But we both are, or all of us here at Sinai are very aggressive on using also IVL therapy as one of the modalities, adjunctive modalities in below the knee if needed. But in this case, probably we don't need it. So you're right. We agree with you. We do a little bit of cutting balloon, get that intima really cleared up or get the luminal gain, and then we can decide on how we want to approach from a scaffold or a stent or proximally a stenting and mid scaffold if you're talking about economics and how many scaffolds do you want to use and get the result. Because remember, we still have to do the SFA part as well, and that I would be a proponent of, and which Shalini and probably you would also agree, would be use of shockwave as one of the therapies in those cases, for sure. So I think that's why we balance our defining the therapy at multi-level depending on how the lesion is, and the lesion changes both above and below the knee. So give it a cognizant part. And PK, I think, is walking right here, so hopefully we should have some news, but I don't see anything more.
Okay, welcome everybody. We're back live. As you can see, the camera has been fixed. So we tried to go with a serenader while we were coming back on recording, and what we are now doing is just basically going with a 3530-210. And then we're going to decide how to deal with this. Maybe a serenader after that. But right now, 3530-210 Railway. Flora. You have wire? So show me down. Keep coming down, Ray. Down, Ray. Can I see the balloon, please? Can you go RAO, please? Can you go a little more RAO? Dame, this thing is hitting this. Yeah, Flora? Now, where's the tip of the balloon? There it is. That's 300. So we're going all the way down to the foot, which is about right there. So now we're going to go up with the 3530-210.
Got it.
Slowly, guys. Okay, my dear, you're going to have a little bit of discomfort. Go RAO, guys, for me. Thank you. 8 and 10.
Yeah, it's
that's a 353. Well. Okay. Relax. Okay, 1 second. Okay, down. Down. Show me above now, guys.
That looks well above, expanded.
Please. Okay. Okay, let's go up here.
3530?
Yeah, I think so. So we're going now up with the 3530-210. 8,
nice.
10. Oh, thanks, Vishal. No, that's great. So Dr. Kapoor is back with us. So we couldn't get the serenader down, so we're going with the 3530-210.
It's well expanded.
And the idea is now you can see we have a very good lumen size all the way down. And this is what I was talking about. When you're using these larger balloons, what I'm going to do is just go up a little bit here as well, and maybe increase the inflow in this one area we know we need to balloon, which is right about here. Go up here, Ray. 6, 8, 10, 12. 12.
There it is.
Okay. Gonna leave that up there. Down now. Now my wire is clipped on the bottom, right, Rachel?
Yeah, it is.
Okay, good.
Ray clipped it, yeah.
So what we're gonna do is I'm just gonna pull this back into the SFA, and then we're gonna take a DSA in a second. Always there's a chance of perforation in these lesions. Okay, DSA, inject. So here's the DSA picture, and God willing, everything looks good here.
I think all saline flush. Oh, here.
Very nice.
Nice.
So that looks great. Okay, now we're going to come down a little bit more. Our fantastic nursing team's keeping the ACT high. Go, inject. And that's fantastic.
Wow. Wow.
So that looks really, really good. Little distal dissection there, which we're going to leave. So what I'm going to do now is walk this balloon out, and now I'm going to go ahead and get some IVUS. Or you want to do scaffolds?
We can do an IVUS just to see.
Let's do a quick IVUS.
Yeah.
What's the matter, my love? She's okay. So I'm just going to go ahead for everybody at home is to do a quick IVUS. And then we're going to put a couple of scaffolds in. Dame, give me 2 375 longs. So I'm just going to go in with the IVUS now. We should have no problem going all the way down. So the area we know distal is going to look terrible. We know that. So the area is where is it going to be the scaffold. So this is all the way distal. Okay, as you see, it looks terrible.
Yeah.
On, record, everyone. Show that on the screen to everybody.
It is.
So you can see the dissection right there is quite bad. And as you come back, and I think this is where I mean, personally, I think we should run an atherectomy.
I would.
Yeah? No? Or you want to do something?
Well, it's all about the length too. I mean, my direction atherectomy, which I'm sure you're going to do like an EXL going down there. We could do an atherectomy. Worst case, we have an atherectomy serenator open.
Yeah.
We could do that as well and give
See,
it
over here it's pretty good. Yeah. Let's open an EXL, guys.
Yeah, open an EXL, please. Yeah, see right there.
Yeah, so all this needs to be cut out.
Luminal gain, yeah.
You know, and then we can put a serenator down and then decide. Okay. So you can see it's pretty bad. So, but we got flow. The question is, how are we going to maintain our results?
Correct.
We don't have a sirolimus-coated balloon here. So we're going to do a quick EXL. So as Wen is measuring the lesion, it's 3.5 proximally. Distally, I'm sorry.
Wow, it's a big vessel.
And proximally is probably 3.75. All right. Yeah, it's a 4.4, but I think that's a little generous measurement. I'd probably go with a 3.75 proximal, post-dilated to a 4.25. I think should be fine. So the technique of atherectomy here is just going to be a single quadrant cut. And what we're going to do is we're going to go ahead and get it down there. I know people don't believe in dottering here. I don't think you need to dotter because of the fact that it's not a CTO. But I think definitely there will be a option to dotter here. But what I do and usually is just to dotter it down and then pull the wire, please, and then have the ability to make sure that the atherectomy cutter doesn't stall in one particular area. So what we're going to do is we're going to go Flora. So as I go down, Vishal is going to turn on and off when I ask him to. I'm just going to go all the way down proximal to distal as far as this thing will go. And it's quite a good length. So you can see we got a long way to go. Going to almost pretty much get into the foot. That's hubbed. And I actually have a little bit of room to go further. But what I'm going to do here is just come back now. And then have Dr. Kapoor turn it on and off as soon as I get a hold of my wire.
Yeah.
Okay, ready? I'm going to cut immediately here. Come up top, Ray. Okay, on. Off. On. Off. On. Off. Okay.
Yeah.
Now I'm going to get a 3.30 serenator, guys. 3-0 serenator quickly. And then I'm going to take the serenator all the way down. And Vishal, can you talk about how the serenator works?
Yeah, so it's a cutting balloon which has like 3 stainless steel longitudinal along the long axis of the balloon. So it is serenaded edges. So those blades, so to say, actually try to cut into the intima and into the plaque to give you more luminal gain. But like I said, it has 3 serrated edges. It's not like a wire wrapped around. And we've had good results with it. And again, like PK talked about, it's a little bit bulkier balloon, so you might have to use a so-called atherectomy balloon for increased deliverability, but it comes in different sizes and lengths all the way from 40, 80, and 120 is the longest length. So, and the sizes now, they've actually gone to a 6-0 size as well for the SFA lesions in case needed, but below the knee, they go from 2.5 or 2025 all the way up. So,
where's the right
there. It's at 350. It's approaching 350 right there. That's good. You're across. You're right at the ankle, close to the ankle.
Okay, good.
Perfect.
Okay.
Yeah, so the technique here is you don't go all the way. So they say 2 minutes, 4 atmospheres for a minute and then 6 atmospheres for another minute. The idea is to have a controlled dissection and not quickly go up and go down. So thereby increasing the luminal gain while causing decreased chances of flow limiting dissection. So you're going to see we do 4 for a minute and then 6 for a minute, and we go from there. So there it is.
So that's at 4 right there. So we're going to 4 for a minute and then 6 for a minute, and we're going to pull back.
It's stuck to the eye. Thank you. Perfect. Good. I didn't want to make sure it doesn't fall. Okay. Perfect.
So then the scaffold size, we're going to go with the 375 in the ostium, right? Okay. Down? 6? I mean 6?
Yeah, 6, and then we go down.
Now for a minute.
So PK strategy in this case is like to scaffold the mid segment where you saw the.
I think I'm going to scaffold just the ostium. I mean, we don't know what the right answer is, obviously. We don't know the mode of failure of these. I mean, obviously, you and I know from our work with the DCB that this is likely because of recoil. So let's take an angiographic picture and see where there's the highest recoil and put it there.
Correct. That's true.
Down?
All right. Perfect. Down.
Walk it back, Ray.
Got it, Sean?
All right, just walk it back. Ray, please get over there, Ray. Walk it back. Okay. Stop. You went too high. No, you're there. Come to 300. Come to 300. A little more. Let's go up there.
Okay.
So we're going to have to do 3 serenations here. So there's going to be at 4 atmospheres for a minute. Yep, 4 atmospheres for a minute. And then hopefully this will look really nice.
Yeah.
And then we can decide on the scaffolds.
That's true.
So once we do the scaffolds, now, Vishal, can you play the SFA pictures?
Yeah.
So our plan for the SFA is going to be a shockwave and balloon of that one segment right here. So Dame, can you set up a 6-0 shockwave? It's already there.
We have it right there. Open.
So let's sit it up. It's going to be a little lower than this.
Yeah, it's going to.
Next, right there. So that's going to be a 6-0 shockwave followed by a DCB, or maybe we'll just put an alluvia. And then down below, we're just going to use a DCB at that tight lesion right there, which I just ballooned.
Correct. Yeah.
So we'll do a 6-0 shockwave followed by an alluvia.
No, that's good. All right.
Okay, 6 atmospheres, guys.
Yeah.
Okay, for another minute. So I think this Vishal, this kind of balloons really do help in getting a better luminal gain, which I think is going to be very helpful for us. Okay.
Yeah, I think that's what me and Raman were discussing, that in case for below the knee, definitely there is no role of IVL therapy as of now. We just do your atherectomy, atherotomy.
And one more time, Ray.
And then the scaffolds when we have to. But in above the knee, like especially in this SFA lesion, we definitely use an IVL therapy to give us the maximum advantage that we can. So I think we just...
Okay, go up again. We're going to do 4. As you can see, the inflations of these devices and the lengths of these devices, we're at 4 atmospheres, takes a long time.
Yeah.
So at this stage, we're, again, with our delay with the equipment and all that, it's going to take a little bit of time here. So I'm going to leave it up for a minute. It's very important to follow the manufacturer's recommended inflation times, because as you can see, bottom line, you want to be able to allow this to really, really expand. So
So PK, regarding the using the bioabsorbable scaffold, antiplatelet therapy, 1 year?
1 year is what they're recommending at this stage. We know obviously the recommendations and the guidelines have changed, 6 atmospheres, but at this stage, I think we have to follow this 1 year guideline at least till we get more information with Xarelto and or with you know the NOACs.
Right. Okay.
So down.
No.
And then proximal at the. Go up to R, Ray. And more. Okay, go up there, guys. So go up here to 8. Go directly to 6.
Yeah, because
it's very large here. And then go up to 8 here.
Nice. That's a tight lesion right at the bend.
And then 8. Yeah, 1 minute and then 8. Yep. So hopefully this will improve our flow, and then we'll decide with the bioabsorbable where we're going to put the scaffold.
Right.
Yeah, it was unfortunate that we had a little technical issue, but you know, anyway, we're still going to record it and show you guys everything that we would normally do. Go to 8.
Yeah.
Okay.
Perfect. Let's give some nitrite.
Right. Down. Okay, just walking back now.
Can I have some verapamil, please? What's the heart rate? 62. That's okay.
Right. Just pull it up. Pull it out, Ray. You can just pull it. I got the wire here.
Here, Ray. Give some nitrite before we take a picture. Is it 50 mics a cc? Nitrite? 50 per cc. Okay. Yeah, just giving a little bit of nitrite just to make sure we get a good angiographic evaluation. So, okay, good. 100 nitrite. Okay. Oh, wait, let's take a picture and then, yeah, SP is right there. Wow, nice.
Much better vessel.
No perf, no dash.
No perf, thank God. Beautiful.
Beautiful.
Okay, that's good so far right there. So now let's analyze the angiogram, see where we'd want to put the scaffold. Let's take one in the mid here.
Yeah, I think it's...
Everything, maybe right there.
Yeah, exactly, right where the collaterals come.
The collaterals, yep. So let me make a roadmap there. Center it a little bit more. That's where it seems to be the highest recoil is right here.
Right at 150.
Yep, that's the best area to put it.
Yeah.
All right. So Ray, we're going to go in with the scaffold, buddy. So everybody at home, I mean, the scaffold basically is a bioabsorbable Aspirin scaffold that's been studied in the trial. This is a monorail system based on a absorbable platform coated with sirolimus. So therefore, you have both the drug and the scaffold on the same device. So in this case, we're probably going to put one right here at the area of highest recoil, which is right in the mid. I've road mapped it, and we really don't know what we're doing with this, but I can tell you that probably the mode of failure likely is going to be the area of highest recoil. So we're gonna go here. So the way to go up on this is 2 atmospheres every 5 seconds up to, I believe, 8 is nominal, right? 9 is nominal, and then go ahead and then take that to
30 seconds.
for 30 seconds at nominal, and then you can post dilate it up to 0.5, which we're going to do here.
You like that?
Right there, Ray? That's good right there?
Yeah.
Yep. So we're going to go up with this scaffold, and then we've already prepped a shockwave balloon, and we've got this, give me a long Alluvia stent, please. 6-hole long.
All right, fluoro is on.
Yep. There's 2 atmospheres you can see going up.
Yes, in this case, like people talk about, it's all about the sizing part of it. So if you have IVUS, the vessel is
3.5 here.
Yeah, so 3.75 is a good choice. You can go up to maximum 0.5. They don't want to go higher than that.
Exactly.
Otherwise, it ruins the integrity of the scaffold itself.
Exactly.
So proximally, if let's say, God forbid, we had to decide to do it, we'll end up to our old school drug-eluting coronary stents if we had to in the proximal segment, if PK agreed to that one.
So, I mean, let's decide what to do. Give us a 4-0 Abbott, I mean, a 4-0 post-dil balloon Pete, coronary. So now now let's come off roadmap to show everybody at home. Now you can see the scaffold mag up, Vishal.
Yeah.
You can see when you look at the scaffold very closely, you can't see anything except the markers. You see the markers? The markers are what's going to tell you that where you landed the scaffold. The scaffold itself you cannot see. So Ray's going to walk this out. We're just going to do a DSA as soon as he walks it into the proximal area. And you notice he waited till it completely ran down. And now we're going to cine. So we're going to show you the scaffold, post-scaffolding, how it looks. So here comes the run.
It's filling the...
It's filling.
Oh,
obviously a lot of saline here, but very well opposed. We're going to post-dilate that. It's recommended right there. We're going to post-dilate this with a 4. So 4 millimeter, 4/020 is fine.
Yeah, so the markers that PK is talking about, there's a marker on the left of the wire, if you see, and proximally, and on the right of the wire distally. So those are the two end markers, and that's where that's how you identify it on a fluoroscopy, and so that gives us where the landing zone is for the balloon. So you're going to see sometimes it moves because if the stent is right up there. So just have to be careful of that part, especially when you're passing your post-dil balloon. But it's always recommended to use a post-dilatation in this case to give the maximum benefit. Yes, pull? Okay. Let me know. Good? Here, Shalini, hold
Flora?
this. Yeah, Flora is on.
So now you can see here, as we're coming down, we're going to come all the way down to the across the scaffold. And again, I don't really think geographic miss matters here because we already geographically missed this because we didn't put a scaffold for the whole lesion as was done in the study. So we're extrapolating quite a bit. Right there is good. Let's go up now to nominal. Nominal is, Dame? 12.
Ready?
12. Okay. Down. And then maybe a little distal and go up to 12. Dame, you know what I'm thinking? I'm just going to Dorado it. Let's Dorado. Forget about, actually, we've got the shockwave open. Let's
have the
shockwave. Yeah, go up. 12.
Nice.
Down.
There it is.
And then proximal. Maybe we might not have to scaffold it. You're right. Proximal.
A bit more.
Go up here.
Right there.
All right. 12. All right, good.
Perfect.
Good. So now we're just going to walk that out. Just pull that out, guys, and let's load these this balloon now.
The shockwave.
You can just pull it out, Ray. We've got it through and through.
Yeah, we have it through and through.
Beautiful. No more recoil.
Nice.
So we took care of that segment, which is fine. A little dissection distal, but that's part of what we're dealing with.
Okay.
You know, Flora?
Yeah.
And remember, in the DCB studies, the dissection didn't matter in terms of restenosis. I think it's right here. Yep, right there.
Yeah, 1 at 150.
I got wire, Ray. A little lower.
We start at 200.
It's going to be around 200.
Yeah. That should be good, I think. No, I think that's perfect. You want a little bit more?
It's lower, right? Go show me the run.
Hold on. Oh, let me go forward.
Yep, play that.
Yeah.
I think it's below 200. See, there's 200 has to be taken care of, but it's right below that. See right there.
Yeah.
Actually, 220, 250.
250 is the
Go
best.
to 250. It's actually into the other stent, Ray. Flora?
Flora. Maybe, yeah, it's better to start from there.
A little lower, guys. Okay, now pull it back, Ray, a little.
Pull it back.
That's it, good. Good. Go up to, okay, so we're going to shockwave now.
4.
Okay, go ahead.
Off. Good.
Flora?
Flora? It did give way.
So, Vishal, for those who don't know, shockwave, go up again. No.
No.
Why are you coming down? Go up.
6.
Go up to 6.
Because we're going to reboot it and then I'm going to fire one more time.
You don't need to come down to go up every time.
Yeah. There it is. So now
Very
you can see it's
tight.
expanded. Yeah.
It's not fully expanded yet.
Yeah.
Gotta go AP. See? It's not fully expanded. Starting to right there.
Yeah, it's giving way, but
Okay. Go to 8.
there it is.
I'm at 8.
Let's go restart. Okay. One more and then we'll do one balloon length back.
One above that.
Yeah.
Actually, you can do a couple above that.
Yeah, good enough.
So when do you choose to scaffold, Vishal, versus not down?
Yeah, I mean, in this case, it's a long lesion. If you really
Go
go
back.
long, diffuse and stuff. So I would probably, if I have to, I would
Back
probably
more.
just do a long DCB. We have 250 DCBs.
More? Okay, go up there.
Okay. And then if I have to do, I do a spot stenting with a non-drug eluting, whether it be Supera or any other kind of non-drug eluting stent. Yeah, because in this case, if you look, the disease does extend diffusely both up and down the tightest spot is what you did shockwave at, which is correct. But normal to normal segment, essentially there is a Supera right there anyways. So if you have to, we can just extend it all the way approximately after putting a drug-coated balloon.
Right. Laura, please.
Okay. Because the longest drug-eluting stent, either Illuvia or Zilver, we have is 140.
150, I believe, Illuvia.
150, yeah, that's true. 150, my apologies, yeah.
Go up.
Go up to 8. Yeah, good. So we have Illuvia. So if it covers in 150, then yes, we can probably just
this shockwave balloon is 80?
Yes. Oh, it's a 60.
60, so it's 120. 60 or 80?
80.
60, so
This is a
120.
60. Yeah, then we can probably just...
I think that's all we need here.
Yeah, I agree.
Go to 8.
We're at 8, yeah.
Can I go down and do the distal tibial, Ray? That area?
The pop.
Oh, the pop.
Yeah. Okay. Floro. All right, let's go.
Come down. Right past 400. A little more. A little more. A little more. Right there. Let's go up there slowly.
I'm going to go 2 first. Then see. Right to the pop. All right, go. Fire.
You can see all the outflow disease here, Vishal, causing the problems.
And look how the lesion gave way after the initiation of shockwave therapy. Again, you're right. That's a very good.
Go to 6.
I'm going up to 6.
Keep it up. Yeah, we'll do one more.
And then I'll pull back and do one more.
Okay.
Go ahead. We have plenty of shocks left.
Yeah, we do. We still have 3 more after this. I think will suffice. So now in this case, like you say, the lesion technique starts from 400 all the way back up.
Right.
To 150 or 100. So a 250 long balloon.
Down?
Yeah, down. And then we're going to go a little bit back.
Pull back a little and do one more into the stent. Okay, go up there, brother.
Good. Go.
Look at that lesion.
Yeah. 6.
We would have been done with this by 9. Unfortunately, Alina pulled the plug. She was like, enough. I'm leaving. 8.
Feel like the holiday start today. That's it.
Holidays start today.
Yeah, we're in the Supera, so I don't know how much game we're going to get. Okay.
No. One more time. Let's talk.
I'm going to go one more time. Go 8.
So you went from 400. Let's get a 300. What is it called? Ranger, right? 6.0 300 Ranger. Let's take a picture. Make sure we didn't dissect this.
Exactly. Especially on the distal part. Just want to make sure it's size matched, which I think it is. Okay. Perfect.
Okay, walk it out.
Yeah. Hold on. Let it come down.
Down. Let it come down.
Let it come down.
You just pull it out.
Okay, now pull it out.
Sheet. Just pull it out.
Yeah, it's okay.
No,
the wire is attached.
You just have to, You just have to do this. That's all you have to do. Okay, inject DSA, Cine. The distal area is still not expanding.
Yeah.
Much better flow.
Definitely
We'll go the Ranger down there.
Yeah.
Might have to stent that, Vishal.
I know. We could probably use maybe use a Dorado there.
Let's see what the Ranger does.
Okay. Perfect.
Make that a roadmap, guys.
Yeah.
You want to do the scaffold of the ostium? Yeah, that's a reasonable idea. But let's see how it looks, and then we leave it alone. Let's see if we'll figure it out. So the discussion here from Ray is that should we take care of the ostium that was CTO'd with a scaffold? Okay. But the question here is how much are we going to do in one setting? I think we've done a lot. I do agree. We can put a bare metal. We can put a DES.
Yeah, that's fine.
You guys want to put a DES in the 4.0 DES in the proximal?
Yeah, that's what I was talking about. You just probably do a 4.0 DVS to at least make sure all the hard work stays.
Let's see. We're probably going to put a 4.0 DS in the ostium, which was occluded as Ray said, and then we'll see how that goes. We'll get a 4.0 long. Yep, 200. That's fine. And then let's get a 4.0 DS, 4.0 long DS. So we just have to go to the R.
Here. We got it? Okay. I'm going to get the wires. Oh, no, it's okay. Good. Yep, got the wire. Go to the other side. Hook up the interferator. That should be good.
A little back, Ray. Slightly.
Hold on. Let me pull it back.
That's good. Let's go up.
Yeah.
What's nominal here, guys?
Got it? 8. Okay, 6. Longs are 6. Yeah.
Off-road map?
Yeah. Mm-hmm. Yeah. Nice.
Now show me above.
Mm-hmm.
Good, we covered it. No. Oh, almost.
Oh, yeah. Probably need one more.
Go to 10. Leave it up at 10.
3 minutes.
3-minute timer.
Yeah. So I think now your strategy is to put another drug-coated balloon proximal.
I don't know. Let's see how it looks angiographically.
An
We covered that initial lesion, that really tight one.
Yeah.
And I think we'll just put a DS below, and then we may be done. I mean, that's the whole point. How much are we possibly going to do here?
Exactly.
So, that's the question.
Yeah, I think we did good shockwave therapy, and if you apply DCB, I think in this case where there's like focal calcified lesions, the long-term patency should not be an issue. Yeah, if you're right, if it was a complete CTO or an ISR, CTO-ISR, then probably your strategy would change to a point that now we start to go more aggressive, another layer of stent, all the stuff, versus do a drug-coated balloon technology with a good outflow, with scaffold and a stent in there, and hope that the patency is there. I think the key here is
we've achieved a good outflow.
Correct.
I think that outflow is really, really going to help us to keep this open in the long term.
Okay. I think that's a very good point too.
And I think that's why Dr. Kapoor and I first started with the opening of the outflow first, and then we did this.
Yeah, especially in this patient who's a recurrent, came in here for worsening symptoms, and I think it's always good to have a good outflow in there to establish, to at least relieve a rest pain, which is what our goal eventually is. So
exactly.
And if you're right, if you had another vessel runoff, then we would have probably not gone after the AT. But in this case, there's literally nothing going down below the knee at all. So this will definitely give a huge benefit. And the flow was so bad, yeah. So I think it's definitely there. Another 30 seconds.
You can open it. 4048 open. So we're going to put a bare metal, drug-eluting Jardiance off-label into the AT.
And the good thing is there is data from the drug-eluting stent trial of Yukon Destiny to show that the drug-eluting, especially in the proximal part, does have good beneficial outcomes with long-term patency. Mm-hmm. So I think that really justifies in this case to use one end.
Just walk it out. Yep.
Yeah. Okay, ready when you are.
DSA.
It is. Wow.
We got to stent the ostium now. You can see the ostium.
Yeah, now it looks even worse because they have better flow.
We're going to do the ostium.
All right, right. Is it 4-0, 4-5?
4-0.
Okay. Have it right. Got it? Perfect. Okay. Let me center it. Oh, sorry. My bad. I got it. Stop.
A little down, Ray.
There's a lesion.
A little down?
Right, go down. Just a touch.
Yeah.
Perfect.
Oh, well, let's take a DSA.
Yeah.
A little bit more down. Actually, this is okay. Actually, come down a little bit.
Come down just a touch. Stand.
Oh,
well,
back,
too much.
Back more.
Let me.
Right there. Right there. Go up.
Go up.
Hmm?
Going up.
Nominal, Dame.
12, 12.
Go to 16, 18.
I am.
18.
Mm-hmm.
Good. Down.
Got it. Fluorocept. Let me go one more time.
Mm-hmm.
Okay. 1, 2, 3.
Mm-hmm. Yeah, walk back.
Wait.
Go up to 16, 18.
Nice.
Good. Down.
Mm-hmm.
Then go in and go to 6, Ray. More. Okay. Yep. Mm-hmm. Yep. Go to 6 now.
Six.
Okay, good. Down. All right. So we're pretty much done here unless we have a proximal dissection, which I don't think we will.
Yeah.
So walk it out.
Mm-hmm.
Okay, DSA.
Yeah.
Inject.
Wow. Looks gorgeous.
That looks really good so far.
Even distally looks beautiful.
Yeah, let's look at top proximal, Ray.
Mm-hmm. Let it fill.
Up top above the supera. A little higher. Good. Cine.
Hold on 1 second. Yeah.
I think we leave.
I think we're done.
Nah, I leave it alone.
Yeah, I agree.
Okay, wire out.
Looks
Let's
good.
do it. Knife pride. Foot shot. Take the wire out, Ray. Yeah, from. Yeah, I would just pull it out.
Yeah. Oh, look at the bleeding. Nice.
A lot of bleeding now.
Yeah. Yes, please.
Yep.
I'll throw this trash. Yeah, I got it. Don't worry about it.
So everybody at home, it was a long, drawn-out case because of the issue. But now we're just going to go ahead and once Ray gives knife pride, just flush it through. Wait.
Short 7.
Start from here.
Ready?
We'll take one here and one down.
Start with the foot, Michelle.
I'll start with the short.
Move your hand. We can leave it.
1 second.
Okay, Cindy.
Yeah, ready when you are.
Cindy now?
Mm-hmm. It's all saline. A good flow still there. Normal. Look at that.
We're a little bleeding, which we expect. Come up top.
We want it to bleed. Look at that.
And then up top. A little higher.
Good.
Cindy. All right. Well, thank you, everyone. Great job. We're all done. So thank you to our wonderful nurses, Damien, everyone, for helping us. So we're going to close this growing up, and we'll see you in the new year. Happy holidays. Happy New Year.